Good afternoon, everyone. Thank you. Thank you all for being here for this evening or this afternoon's Open Book, Open Mind presentation here at the Montclair Public Library. We appreciate you coming out on your Sunday afternoon for this event. Our Open Book, Open Mind series is made possible with generous support from Susan and Thomas Dunn and the Montclair Foundation. We also want to thank Partners for Health for sponsoring today's conversation. And we'd like to invite you to our next two Open Book, Open Mind events that we'll be having. On Tuesday, May 9th at 7 o'clock, join us here at the library as Bobby Brown discusses her new book, Beauty from the Inside Out. And on Friday, May 19th at 7 o'clock, we hope you'll join us and maybe bring your teenage children if they want to be seen in public with their parents for a very special event at the Montclair High School featuring author Marina Budos, who will discuss her new young adult novel, Watched, about a Muslim teen who is forced to turn informant to a pair of detectives looking for terrorists in Queens. And as part of that, we'll have a spoken word performance inspired by the novel performed by Theater 167 from New York. After our program tonight, books will be available for purchase from Watchful booksellers in the lobby, and then staff will direct you to line up for the book signing portion of the program. We are so grateful that you're here tonight to support us in this event, and we're thankful that you guys love your library enough to come out on a Sunday. But you didn't come here to hear me. So I will introduce Dave Jones with the Montclair Public Library Foundation, who will give us more information about our guest speakers and our program tonight. Thank you.
Thanks, Peter, and thanks to you all for coming. Who could not? This is such a great group. My wife is saying you can't hear me, so always need your wife to tell you, you know. I'm really delighted to introduce these folks, this amazing group, to talk about Elizabeth Rosenthal's new book, An American Sickness, How Big Business Took Control of Healthcare and How to Recapture It. And this book is now, this week is number 6 on the New York Times hardcover best-selling list. With her this evening as a moderator is Montclair resident Richard Besser. Richard was just named this month as the president and CEO of the Robert Wood Johnson Foundation, the largest health philanthropy in the United States. Prior to that, for several years since 2009, he was ABC's chief editor of Health and Medicine, during which he was involved in the winning of an Overseas Press Club Award and 2 Peabodys. From 1998 to 2009, he worked for the Centers for Disease Control. He was acting director for several months in 2009 and led the response to the H1N1 flu pandemic. And he won a Surgeon General's Gold Medal for his work in that area. Prior to that, he spent 5 years on the faculty of University of California, San Diego. He has a BA in economics from Williams, an MD from University of Pennsylvania. He was chief resident in pediatrics at Johns Hopkins, and his specialty is pediatrics and infectious diseases. Elizabeth Rosenthal this year became editor-in-chief of Kaiser Health News, a foundation-funded website that has more than 40 journalists covering healthcare issues. It's based in Washington. Prior to that, Libby spent 22 years at the New York Times, 6 of them in Beijing, the last 9 as the National Environmental and Healthcare Reporter. In 2014, she won the Victor Kahn Prize for Medical Science Reporting. She has a BA from Stanford in, get this, history and biology. She has an MA from Cambridge University, where she was a Marshall Scholar in English literature. She has an MD from Harvard. She was a resident at Cornell. She spent 5 years as a New York Hospital emergency room physician. Richard and Libby, thanks.
Thanks very much. Well, thanks very much, Dave. It's a real pleasure to be here in front of a hometown audience. Libby, I got your book many months ago.
Yeah.
Your publisher sent out galleys to the various networks, looking to see if it would could get some coverage, and I read it right away. The topic really grabbed me, and I immediately came up with all these story ideas that I wanted to do for ABC News around the book. I recommend it highly. But before I could do those stories, I've left ABC. So yeah. I was glad to see Good Morning America covered the book. It really talks about these health issues in a way that I think the general public will really be able to understand and do something about. And what I want to do tonight is follow, in a sense, the structure of your book. Right. Which is, as a physician, makes a lot of sense. It involves diagnosis, examination, and treatment. And right. So we'll have time for all of that. And I want to make time for a lot of questions from you in the audience. So that's great. The first thing I want to ask you, so the healthcare system is the patient. Yep. What's the problem?
Well, the problem, as you and I both know, since we just discovered we graduated from medical school around the same time, is that over the time we've been physicians, there's been an infusion of financial motives into our healthcare system. And that's not to say that profit is bad necessarily, but it is to say that what used to be, and what I went into, the profession I went into as a kind of caring, patient-focused endeavor, is now it's run like a business. And I think the values of healthcare just are really different than the values of business. So that's a big problem if the finances are often dictating your care. And I think the thing that drove this home to me the most is when I was covering the Affordable Care Act, we all wrote so many times, we're innovating for patient-centered, evidence-based care. Patient-centered, evidence-based care. And when I started researching the book, I was like, wait a second, what other kind of healthcare could there possibly be? That is what medicine is to me. And I think the answer is the medicine we see now, which is patient kind of centered, evidence-based sometimes, and finance-driven care. And that's a problem.
There's a lot of discussion in the one comment I want to make. Yeah. I'm here in my role as a journalist, not in my role as the president of the Robert Wood Johnson Foundation. So just to make that clear.
But I will be asking for money for Kaiser Health News by the end of the night.
It's funny how that happens all the time. There's a lot of discussion, though, about the role business can play in terms of making things more efficient, more effective. And so if the system is becoming more higher quality because it's being driven in a business model, what's the problem here?
Well, the problem is, I think at the very beginning, and again, when I started practicing medicine in the 80s, hospitals were horribly inefficient, and that clearly wasn't great, But what happened, I think, is that, we've lost something too in going to this kind of sole focus on efficiency. I remember, and you probably remember, the head nurse of a unit who would lie down in front of a train for the patients on her ward. And, but over time, I saw when I was working in the emergency room, there were people with clipboards saying, is this the best way to do this? Is this the most efficient, And to some extent, they were right. It made sense for hospitals to consolidate because not every hospital had to order its own sheets or order. But what we see at a certain point is the values get lost and the values flipped. So now there's a consolidation. I mean, we all see this. There are a few hospital systems. They've long since garnered the efficiencies that come from consolidation, and now what they often have is effectively monopoly pricing. So I think, if we're rethinking healthcare as a business to become more efficient, that will happen. If we're rethinking healthcare as a business to make more profit, then that's going to happen. And I think we've kind of crossed that line. And when did it happen? At different times in different hospitals. Some places it hasn't happened, and some hospitals are hurting because they haven't done that efficiency thing yet. But I mean, I think the thing that most impressed me as I was researching the book too was hearing from people who worked for Deloitte and McKinsey who'd been called into hospitals in the early 2000s. And the question wasn't, how can we be more efficient? It was, how can we rise higher on the US News and World ratings? You know, how can we game these metrics? Or what they would often tell a hospital is, you can do the exact same thing you're doing now, but if you bill this way for it, you can triple your income. And that's not a good motivation, right? It's very tempting if you're a hospital director, but you know, that's where we see these crazy bills and coding wars coming in, I think.
Now, in your book, you have rules of the dysfunctional medical market, and I want to get into those. But before I do, I want to get a baseline understanding in terms of issues of quality. What do you say to people who say we have the best healthcare system in the world? We do more research, we have the latest treatments, we have the best care available anywhere.
Well, I think that's true if the treatment or the research is profitable. Because we have come to depend very heavily on the profit motive to spur research and to spur treatment. So things that don't have a business model, there's a story in the book of a researcher, Denise Faustman at Harvard, who's been looking into a cure for diabetes with a very cheap old vaccine. You know, it may or may not work, but she got all these promising results early on. People were all excited, and then she went to the people who fund clinical research now, which is pharma, and said, hey, I want to apply for grants. And they said, wow, this is really interesting, but how's it going to make us, you know, how's it going to make us money? Like, why should we invest in this? And even more than that, I think it was threatening because there's a huge industry now in insulin, in pumps, in meters, in treating diabetes. So if, you know, wouldn't it be wonderful if someone did come up with a cure? Well, that would ruin a billion-dollar, multi-billion-dollar industry. So, you know, as sad as that is, I think you can see many examples where, you know, that profit motive did help, right? You know, there's the hepatitis C drugs, you know. Now, I would say you can ask, are they worth $86,000 a year?
These are drugs that will cure
hepatitis C. And, you know, I think that's a complicated business model, and people will say, oh, well, sometimes we do invent drugs that cure diseases. And then, yes, but look at how they're priced, and also look at how complicated it is to treat with those drugs, because as we know, a number of people, and now we see ads on TV, everyone get tested. A number of people with hep C will not have liver cancer. So you're comparing that 86,000 against the people who have the worst outcomes, not against the average person with hep C. And we have no way in this country, and I like to point this out, to try and say, well, what's this new drug worth? Every other country does that, right? And no other country pays $86,000 for those drugs.
Let's touch on that a little bit. So how is it done in other countries?
Well, there's often a cost-benefit analysis that will say, you know, what's a new drug worth? And that doesn't mean they're going to go for like the cheapest. They're kind of balancing it against the social good, against what it will save in terms of medical costs. And so I think there's a much more rational approach. In England, there's NICE, of course, that does these evaluations to see whether things should be covered at the NHS. In Japan, it's done at a national level. And in Japan, the initial philosophy, which I think is quite interesting, is they let new things come in at a really high price, but then they say, okay, but every 2 years it has to come down in price, as things do in economic markets, because it's older. And now what you see in this country, I mean, one of my favorite examples that's used a lot is a drug called Gleevec for cancers. It was you know, it changed the life of many people with cancer, with blood cancers. But now, 15 years later, there are all these what we call sons of Gleevec, right? Me Too Gleevecs. And yet the price has gone up by a factor of 4 or more. So How does that make sense? But we have no way to control that in this country.
So you're hitting some of your rules of the dysfunctional medical market. I picked out some of my favorites. A lifetime of treatment is preferable to a cure.
Yeah.
Is that the issue you were getting at with the vaccine to cure diabetes?
Yeah, and I say this only, it's slightly tongue-in-cheek, but it's also true, right? And someone commented in the book, and again, slightly tongue-in-cheek, if we relied on profit the way we do now for medical advances, we wouldn't have a polio vaccine, we'd have iron lungs in 10 different colors with iPhone apps. And that's tragic, that's really tragic. And, it's probably an exaggeration, but it is where, someone who is looking at this as a pure economist would say, you guys get exactly the health system that the financial incentives in your health system promote.
More treatment is always better. Default to the most expensive option. What do you mean there?
Well, that's going to sound controversial too. And I don't mean that every physician is thinking that way, right? That's not, and that's where I really try and make the point that most physicians in this system are trying to do the right thing for their patients, and we're not incentivizing the right thing. So the example that I like to use of this is a technique for basal cell carcinomas. Skin cancer, not benign skin cancers, called Mohs surgery. I don't know how many in this room have had Mohs surgery. Mohs surgery was invented in the 1930s. It sequentially removes parts of lesions with pathology in the meantime, in theory to minimize the wound.
So during the procedure, they'll take a sample and test it?
And test it. So it takes a long time. You have to equip your office with a pathologist. You need to have all the equipment to do Mohs. And it often requires a plastic surgery closure. Now, it's really great for sensitive locations like around an eye or maybe on a hand. But if you look at the data, it's used now on backs, on legs, and all these other places. And it can cost easily in the tens of thousands of dollars, whereas those of us who trained in the 1980s know that basal cell skin carcinomas, they can be burned off, they can be frozen, you can put on Eftudex cream for 6 weeks. There are a lot of different ways to treat them, but there was a statistic in the book that 2% of people on Medicare each year have Mohs surgery.
2%?
2%, yeah.
That's a lot of people.
That's a lot of people. It's one of the procedures that Medicare likes to call potentially misvalued, meaning we think we're paying too much for this because everyone's doing it and there are too many being done. But I think that's, our dermatologists thinking, wow, I could put a cream on this, but I'm going to do Mohs surgery because my kid, I need to pay college tuition. No, but once you equip your office to do Mohs surgery and that you learn to do it, it kind of becomes your default, and the system encourages that. And I think patients don't know to say, well, what about that cream? Could that work too? So it's not universal, and you do hear from outraged dermatologists. I mean, some of my best sources of the book are people from the profession who are pissed that their colleagues are overusing this very expensive technique when they're trying to be kind of cost conscious in their practice, and it's harder and harder to do so.
You write that there's no such thing as a fixed price for a procedure or a test, and the uninsured pay the highest price of all.
Yeah. Well,
examples?
Do
you have examples of that?
Yeah, I mean, one nice example, and you're moving to the epicenter of high-priced echocardiograms in Princeton, New Jersey.
Is that right?
Yeah. I mean, if you look at the price of an echocardiogram, right, from coast to coast in different cities, different states, I kept getting, I had one patient who was charged $10,000 for an echocardiogram near Princeton, And then he wanted to he had to get a second one a couple of years later, and he went up to a Harvard teaching hospital where it was $800. And
For the same procedure?
Same procedure. And actually, the one at Harvard was more complicated. It was done by a physician. The one at the Princeton Hospital had been done by a tech. And he needed a valve replacement. He did need this. And he wrote to me, he sent me the two bills, and he said, what's going on here? And so we downloaded data about the prices billed for echocardiograms all over the country. And what you saw is that it's just, it looks like a random chart. You know, it's what a hospital thinks it's worth. And that's kind of what these consultants from Deloitte and McKinsey told the hospitals, you know, you decide. It's kind of like tests are, I always liken it to the booze on a restaurant menu. You know, you can charge whatever you want. And it's not really linked to the cost of doing the procedure. I mean, echocardiograms, I think, are particularly vulnerable to this crazy pricing because they don't harm a patient, right? So there's no risk. They're done by technicians often, not by the cardiologists themselves. And you can say, well, maybe it's better for everyone to get one before every surgery. And so they're big money makers for hospitals. And then hospitals decide, what do we want to charge? Now, again, some cardiologists came to me and said, this is crazy because we now have handheld echocardiogram machines that are pretty good. And you know, if you ask, what do these charge, how much do these cost in Japan or in other European countries that try and do rational pricing, it's in the, you know, several $100s. So
Is that for the same procedure?
yeah, for the exact same procedure. You know, these machines are not new anymore. This is not a new technology. And of course, you know, if you're having something really, really complicated, like a cardiac sleeve, maybe you need the ultra latest, you know, directional echocardiogram. But most people just need a kind of simple yes, no. Do you have a problem with a heart valve? And you don't need the like $10 million machine to tell you that. But often it's in the hospital. Once the hospital buys the $10 million machine, it's in their interest to use it. And the thing is that often these machines, sadly to me, now come with like financial guides to how many times you have to use it a year to make back how much you spent. And that's sad, right? I mean, that's not about medicine.
Another rule. Prices will rise to whatever the market will bear.
Well, I think we've all experienced that.
So how does that work? Why would an insurance company be willing to pay whatever the price is that a medical facility wants to put on that?
Well, I think this, I really like talking about this because it gets into one of our misconceptions about insurance. You know, we have come to believe that insurers are on our side, that there are advocates. And
I don't think we'll have universal agreement on that.
right.
I heard a little grumbling on there.
Right.
Okay.
Well, they'll work for you. Well, the bills all say, you know, I love the explanation of benefit statements that say, you know, we negotiated this $100,000 bill down to $40,000. So we say, good news, you know, we saved you 60%. So they do save us from those really, really crazy high prices, which is the main reason in some ways to have insurance, because the uninsured are going to be, hospitals often go after them for those crazy high prices. But, you know, it's funny to me because no one thinks of their car insurance as in your corner or your home insurance as in your corner. They're just what insurers are and what medical insurers are, health insurers are. They're pass-throughs. They take in premiums and they pay out claims. And unlike in the last century, they're virtually all for profit in this country. Their primary constituents are their shareholders, not us. And if the prices go up, as they have in this country, their first response is to pass it on to you in the form of higher premiums, higher deductibles, higher copays. And so I think one of the main things I wanted to connect for people with the book is when people say, why is my premium going up? Why is my copay going up? Why is this drug that was covered last year not covered this year? It's because of these crazy prices, and your insurer, they have a little bit of incentive to negotiate on your behalf, but so long as they can recoup that the difference by raising premiums and deductibles, that's the easiest path. And just one little anecdote, which I think will illustrate this. I had one patient, and this is while I was at the New York Times, who you may have read a story about a young man who got a $117,000 bill from a surgeon he'd never met. He was having spine surgery, this neck surgery, at a hospital in New York City. His primary surgeon was in his network and got paid $6,000 according to the network's, the insurance agreement. And then he got a bill for $117,000 for a surgeon who'd been called in to assist, who was not in network, right? And he went nuts. Like all of my patients in this book, they're really good advocates and they don't let go, even if they're not paying. So he went to his insurer, Anthem Blue Cross, and said, this is absurd. You know, this is a surgery that normally doesn't require a second person. And my main surgeon, who I like, got $6,000. Why is this guy billing $117,000 and I'm not paying it? And his insurer said, right. You don't have to pay. It's out of network. And Peter thought, good, you know, all well and good. This is done. And about 3 weeks later, he was sent a check from Anthem Blue Cross Blue Shield for $117,000 and told to pass it on to the surgeon. And he said, his first response, which is why I love the patients I deal with, was, no way, I'm not giving this that's robbery. And so I called, and at that point I was following the case, I called them and said, why would you write this check? And they said, look, and this was so educational for me. In order to not write this check, we don't have a contract with this surgeon. We don't have a way to negotiate with him. We'd have to send in investigators. We'd probably have to take him to court. It's just easier for us to pay than it would cost us more than $117,000 to fight this. So we'll only fight it if we see a lot of bills from that same surgeon. And their last request was, oh no, are you gonna write about this? Because then other surgeons will know they can do it too, you know? You know, that's, again, it's an example of there are loopholes in the way we do medicine and how we reimburse, and more entrepreneurial people will take advantage of that, and it's sad.
So we're still in the process here of examining the patient.
Right.
And the patient that you're describing, our healthcare system is not looking very healthy.
Well,
Another area that you talk about is drug discovery.
right.
And there's a lot of money that goes into developing new drugs. If you look at the new drugs that have come on the market in the past few years, many of them directed at cancer, using new technologies, looking
Right.
at the genetic makeup of tumors, looking at new approaches to treatment. When you look at the prices for a lot of these drugs, they're extremely high,
Right.
Many hundreds of thousands of dollars.
Right.
What you hear from pharma is that, well, that's what it costs.
Right.
That's what it costs to, if you look at what it takes to take a drug from discovery through clinical trials to the patient,
Right.
this is a fair return on the investment. What's wrong with giving pharma a fair return on the investment?
I think the question is the definition of what's fair may feel different to them than it feels to patients and to a health system. And I think, you know, I'm not opposed to a return on investment. I think other countries try and say, well, what's a fair return on investment? And what you'll hear from pharma often is, well, you know, Germany doesn't pay us enough for these drugs, and that's why we have to charge you guys so much. And my answer is, okay, you know, why are we the suckers? You know, so charge, you know, negotiate. Why don't we all pay the same price? And I think what's wrong with the argument is, first of all, the pharmaceutical companies never really show you what their development costs are. The research shows that they're much lower than the $1 billion that pharma often avers it costs. Much of that research was originally done with public funding.
Through the NIH?
Yeah, through the NIH. When they say it costs $1 billion, it turns out that includes things like opportunity costs. Like if we'd taken that money and invested it in, the stock market, we could have made all this other money. So it's a very fungible statistic, and I think part of me says, hey, if we're talking about opportunity costs, let's think of all the time that patients spend trying to get approval for their drugs and how much that's worth. We don't count the opportunity costs on the patient side. We do tend to count it on the drug development side. And again, I think another part of the problem is, again, that kind of logic in drug development gets you what we see on TV every night. It's these very high-priced drugs that are advertised on television that are often covering very rare diseases. You wonder, why are there drugs on TV, being advertised on TV for stage 4 lung cancer that's failed every other kind of treatment, or non-24, a sleep-wake disorder that affects, about at most 70,000 people who are totally blind.
You have a great section on that.
Yeah.
Can you tell people a little bit about what is non-24 and what's the issue here?
Okay. Non-24 is a sleep-wake disorder that is experienced by people who are totally blind because they don't have circadian cues from light. It is a problem for some people who are totally blind. And I should point out, well, I'll tell you how I found out about this story. And I started seeing these ads on TV. You may have seen them, and thought, what's that? So I started digging into it because that's what journalists do. I discovered that what's being advertised there is a drug called Hetlioz, which is an analog of melatonin. Melatonin, which you can buy over the counter for, 100 tablets for $6. And it's a drug that they have been trying to get on the market as a sleep aid for many, many years. But you can't patent melatonin because melatonin is a natural product. So you create a slightly different molecule that attaches to the same receptor.
Just change it a little bit.
Yeah, it's an analog melatonin, and then you can patent it. So little company patented it, and then they try and develop it as a sleep aid. And they did big clinical trials as a sleep aid, and guess what? They didn't turn out that good, because melatonin kind of works, but it's not like magic, right? So the conclusion of those trials were, yeah, it probably helps a little bit. And anyway, at that point, there were all these other drugs on the market, like Ambien, that were blockbusters, and they figured this doesn't make any sense. So the little drug company didn't give up, and they thought, how can we find a use for this drug that we could market, that was marketable? And they settled on testing it against non-24, this condition that affects people who are totally blind. And guess what? Because it only affects very few people, the FDA has a special approval route for it, which means that you don't have to test it against thousands of patients. You can test it against dozens. This was tested against 60 people with non-24. And it also means instead of using those big endpoints like, does it extend life or does it make you sleep better, they can use what are called surrogate endpoints. And the trials only had to last 3 months. So it's a cheap trial. So when everyone says, it's taken us billions of dollars $1 billion to develop this drug, yeah, maybe because it didn't work very well at first. But then also your major trial, which you took to the FDA for approval, was a really cheap trial because it only involved 60 people over 3 months. So anyway, the company gets this drug ready to take to the FDA. They fill out an application. And what are the standards at the FDA? The standards for the FDA, and these are legal standards, so the committee has to apply them, are is it safe and effective, right? So they get together a bunch of prominent neurologists and sleep specialists to evaluate this drug. And the committee meeting on this approval is so fascinating because everyone on the committee is really uncomfortable, including the guy who alerted me to it, who's a guy named Dr. Robert Sack, who discovered this sleep-wake problem in the 1990s. And they're all like, this is weird. This is like just melatonin, right? And the drug company is saying, don't be so heartless. People are suffering. The pharmaceutical firm flies in patients who say literally things like, being blind isn't a problem. My problem is non-24. At the end of the day, and the last thing is, because we say safe and effective is our standard, it's effective but not compared to anything else, effective compared to placebo, which may have made sense when that standard was defined in the 1940s, where there weren't a lot of Me Too drugs. But now it meant that this little drug company didn't even have to compare it against melatonin or any of the other sleep aids. So at one point, one of the other experts says, sorry, there's so much outrageous in the story. In their test of 60 people over 3 months, this new drug, Hetlioz, it improved sleep. They only measured it on the worst 25 nights of sleep. And on those 25 nights of sleep, it improved sleep from 3 hours to 3 hours and 45 minutes. Sorry. One of the other neurologists on the committee says, wow, that's not very impressive. That's under 4 hours, that's still pretty awful. Why don't you tell people to take a different kind of sleep aid and use an alarm clock? And again, the president of the company says, you're being heartless. How can you say that to people? Take a sleeping pill and get an alarm clock. People are suffering and we're trying to answer a need. And at the end of the day, the members of the approval committee, with great discomfort, say, and this is why Dr. Sack called me about this, we had to approve it because by the rules of the game, it's safe and effective. And they thought, well, okay, so how much could they charge for this thing? It's kind of just melatonin.
How much could they charge?
It now sells for $8,000 a month.
$8,000 a month.
Yeah.
Covered by insurance.
$267 a pill, and an analyst concluded that they only had to get something like 1,500 prescriptions a year to make money. So why is it being advertised?
But given that that it's only for people who have non-24, right, people who are blind, what's the big deal? There's not. I mean, how much could this add to the healthcare burden? That's not very many people.
Well, and here's the rub, and here's why we see all this advertising, right? I kept thinking, what's the end game here? As the journalist, and particularly one, and now I have my antenna up for cost things, what's the business model? Why are we seeing this? And what you see is, what's a sleep-wake disorder that we all experience? Jet lag, right? So the company very cleverly encourages people, once they've seen this ad, to go to their website where you can decide if you have non-24, right? And the questions to decide if you have non-24 to ask your doctor for Hetlioz are things like, am I sleepy sometimes in the day? Do I mean, they're literally, unfortunately studies show that when people ask their doctor for a drug by name, more than half of the time they'll get it if the doctor thinks it won't harm the patient. And of course, also when the detail people, this drug company sent out salesmen to doctors' offices, they didn't go in there saying like, hey, we've got this great new sleeping pill, it costs $8,000 a month. They go in and they say, we've got this new pill and it's an analog of melatonin, but it's dosed much better because melatonin, it's over the counter and you can't know what you're getting. And the doctor has no idea when he or she is writing that script that it's going to cost $8,000. And I don't know, and it takes some, so what will happen next? probably people will go to the pharmacy, and it will either be in your network or it won't, or there might be a huge copay. But it takes some time to catch up with these things, and the next thing now this little drug company is doing studies for this drug for jet lag, and I think that's the end game. They're trying to get brand recognition now, and in a world where some people will spend $15,000 for a first-class seat. Maybe some people will spend $8,000 for a pill for jet lag. I don't know.
I'm going to have to switch in a moment
sorry.
to the treatment side. No, that was
I mean, it's
a very good example of what you're describing in your book. But there's one other issue I wanted to get into. You touched briefly on direct-to-consumer advertising and some of the issues there. But you go after something called the Orphan Drug Act.
Yeah.
And as a pediatrician, I've seen a lot of children with medical conditions that are rare, that there hasn't been much incentive for pharmaceutical industry to look at treatments.
Right.
And so the Orphan Drug Act came along as a way to get research money in, to develop these drugs, to get them to market, to handle kids' disorders that otherwise wouldn't get attention. And at ABC, I used to do Twitter chats all the time with people who had rare disorders.
Right.
And there's a lot of them out there.
Right.
But you found there's a little gaming of the system.
Yeah, and that's the problem. To me, the healthcare, it's the ultimate in the road to hell is paved in good intentions, right? Because these things, something like the Orphan Drug Act, was passed for really, really good reasons, and it's been used to develop some really, really important drugs. I mean, it essentially does a similar thing, that if someone develops a drug for a rare disease.
What is a rare disease?
It's under 200,000.
Under 200,000 people.
People in the U.S. There are a lot of financial incentives to encourage that, and you want that because otherwise, why would anyone develop? There's no financial. If we're counting on the financial motivation, it's important to do that. But then what a lot of people say is, as with this drug Hetlioz, we're not going to market this drug for the big picture because that would require these huge studies. We're just going to market it for this orphan condition, non-24, for totally blind people. So I think the problem is it encourages a lot of good research. It also allows people who are business people, who are, the people who run pharmaceutical firms. In my day and age, they were often, the retired chief of medicine at my hospital where I was a resident went to work for Merck in infectious diseases. Now, he was an eminent physician. A lot of these companies are now run by business people, and they're looking for business opportunities. And if you're looking at it as a business opportunity, you think, wow, let's go after this orphan disease because we can charge a whole lot and we won't have to do a lot of research. And so, it's all a question to me of motivation. And I'm fine with people profiting, but only if their motivation is kind of to help the most people they can with that drug, and in a way that has a sense of the social value of that drug too, because if Medicaid or Medicare or our insurers are paying, $500,000 a year for an orphan drug, then when in other countries they're paying $50,000, that's a lot of money we're not using for other things that other kids really need. So I think, there's the small picture and the big picture.
One of the things that I always counted on was the whole generic drug world as the way of thinking, okay, there'll be a recouping of investment early on, and then the drug will be available as a generic, and it will be cheap, and that's fine.
Yeah.
That's
Sadly.
not so much the case.
It depends a lot on the drug, Some drugs we see that generics have really brought down. Ambien, really cheap now, or Zolopidem, the generic for that sleeping pill. $5 clubs at Target and Walgreens, stuff like that. But what happened again, and it's this infusion of the kind of financial considerations into this industry in such a big way is, there's no reason why generic drugs are not inherently cheap, right? It's like insurers being in your corner. They have traditionally been very cheap, but then someone comes in and says, I don't know, why are we only charging, 5 cents a pill for doxycycline? Why don't we see what happens if we charge $2 a pill and see if the market will bear that price? And lo and behold, it does, right? And so there's this constant testing of waters in the generic world now, where some entrepreneurial drug company, generally a small one, will come in and say, let's get this. There's one wonderful story in the book, a guy named John Siebel, who's an oncologist, and his grandkids had pinworm, which isn't, you know more about what that actually is, but it's treated with a very
Itchy.
old, what?
Itchy.
Itchy,
Yeah.
very old drug called albendazole, and he prescribed it for his grandkids. They took it to the pharmacy and they said, oh, that prescription's going to be over $1,000. And this and
Used to be $1 a pill or
What?
less. Yeah.
yeah, and so Dr. Siebel called the pharmacy and said, what is going on here? This is sold in most of the world for 5 cents. And what had happened was one company there isn't a huge market, cornered the market. Maybe I think there were 2 companies in the US making the drug. And they just tried to see what the market would bear. And they kept raising the price. And insurers kept paying it, right? And there's a phenomenon in pharma which is called, fascinating phenomenon called sticky pricing, which is the opposite of the way economics should work. One manufacturer raises the price. Instead of getting a price war, you have one raising the price and the other's going, oh, look, that worked. They're paying it. And then everyone just comes up to that sticky ceiling. So, Dr. Siebel, knowing that albendazole in Canada is just as good as albendazole for $1,000 in the US, ordered it for $1 a pill in Canada. So I think, there's nothing inherently cheaper about generics. And now that we have really pure business practices moving into the world of medicine, people see a market opportunity. And the FTC often has very little, you would say, well, if 2 companies are making it, the FTC could come in and say, there's not enough competition. No, well, and the FTC can't, because they would say that monopoly happened naturally. There's no active collusion, right? People dropped out of the market. And beyond that, economic theory says, okay, if this drug is being sold at $1,000, other drug makers will now move in and start making it, and that will bring the prices down. Now, that's fine if there's easy entry into a market, but it's hard to start making a drug. You got to get FDA approval, you've got to get a factory going. So the barriers to entry are so high that it just doesn't happen.
Well, I want to dive into some of the treatment. The patient is quite ill. And then in a few minutes, I'm going to open it up to all of you for questions. So be thinking about what you might want to ask Libby. So when you think about healthcare and what people are looking for, they want a doctor, a medical team that they can talk to. Right. They want to get high quality care. They want to pay a fair price, but not go through what you're describing here.
Right.
So where do you start? Where do you start even looking for a doctor who's going to provide that to you?
This is a tough question, right? And what I wanted people to understand is there are ways to approach this. It's not easy, and it's kind of a, when you're sick, you don't want to be thinking, how much is this going to cost? Am I being ripped off? What's the motivation for ordering this test? But I think there are ways to think about the system in a way that not only will save you money in the short term, but it will make it more responsive to patient needs, which is the goal of the second part of the book, really. For example, and I use some of these techniques myself now, because I learned a lot in researching the book. When I go to my physician in New York, who I really love, I will now say, okay, you want to send off blood tests? Well, send it to a lab that's in my insurance network. And don't send it to your hospital lab, because those of you who are physicians in the room know that many physicians' computers are programmed now when you click a blood test order to send it to his hospital's lab. So, which is likely going to be when there's a huge variation in price, the hospital lab is probably the most expensive. So there was one example, vitamin D test, $700 in the hospital, $7 at Quest.
So how do you get past this power differential, though? So, it's one thing, you're a doctor seeing another doctor, but most people, when they come in to see their doctor, there's a real difference there in terms of power. How do you even ask that question?
Well, and I think what I hear from physicians is they don't like their patients being ripped off, right? They're often as upset about this system as any patient is. I hear from surgeons. I heard from a group of surgeons in conservative red Wisconsin who were really upset and are now supporting single payer. And I'm not saying that's the only answer here, because they said they had too often had taken out a person's appendix and then realized they'd bankrupted the family because of the hospital charges. And that didn't make them feel good about medicine and what they were doing. So my sense is most doctors, and more will be if we start asking, are willing to work with their patients on these things. And I encourage, I spoke to the American College of Physicians last year. I speak to residents often, and they want to know these things about prices. They want to help their patients. And I encourage them, open up the discussion, because it's hard for a patient to do. So I hope in time this will be just a normal part of our conversation with our physicians. And more than that, I hope it won't require a great deal of exploration on the physician or the patient's part, because we'll ask these test centers, the hospitals, to let us know what things cost. Often if you go to your doctor and say, how much is this colonoscopy going to cost? The answer will be, I don't know, and I've asked the hospital, and they won't tell me. They won't give me an answer. So I guess what I'm asking is for physicians and patients to partner in this.
So you're not,
Quest.
I could see people reading the book and coming away saying that you should approach the healthcare system as in an adversarial relationship. How do you get your medical team to be really part of your team?
I think, first of all, they should think of it, they have to start getting in that mindset too, and they are. In Australia, it's considered a patient's right when they go into for an elective procedure to have a binding estimate of their costs, and it's considered their primary physician's responsibility to find out from the anesthesiologist and the pathologist and everyone how much it's going to cost. And the Australian Medical Society endorses that approach. So I think once we have everyone on board, it will be normalized and easy. And
so you get an estimate when you take your car in for work, but you don't get the estimate when you take your body in for work.
Yeah, and the other thing I think we have to work with our physicians on and change our attitude as patients is we have a culture in patients and in American medicine of, you got to do something. My knee hurts, I want to know what it is.
Yeah, so there was something you said that in your book that caught my eye. So there's this bias in medicine that early treatment is always the way to go.
Do something.
But you talk about in here basically hurry up and wait. That there are certain times when you're sick when you should not just go to your doctor. What do you mean?
Well, you should not just go to your doctor, or your doctor should with you say, we all learned a technique in medical school called watchful waiting, right? It's hugely underutilized in American medicine because there's no revenue source. I mean, there's no revenue source. And P.S., as a patient, we're primed not to like that because, hey, and I feel the same way. I'm paying, maybe if I haven't met my deductible, $300 for this doctor's appointment, and she says, come back in a week and let's see if it's better. I'm like, no, I don't want to pay another $300. That's crazy. So I think it's a structural problem with the way we interact with medicine, with the way we pay for medicine. It's why these global payments may make a lot of sense, where, you know, hospitals or practice are paid a certain amount for everything a patient needs during the year. Now, the other thing is, you know, we like tests. You know, my mom always complains to me when she goes to see a doctor, you know, well, I saw the doctor, but she didn't even order any blood tests, you know. We feel ripped off. And doctors hear that too. You know, they feel like, well, I better write a prescription, or I better get an x-ray, because I don't know if my patient's gonna feel satisfied if I say, let's just wait. And I think that's something we've got to move back to culturally in medicine as well.
I found whenever the Preventive Services Task Force, this is the government body that recommends screening, whenever they would come out with a recommendation for less screening,
Right.
and I would go to report on it and say, well, this is good. They looked at the evidence and there's less screening. The producers were very skeptical,
Right.
and said, well, it's got to be about cost. It's got to
Right.
be about saving money, not
Right.
about improving health. It's like, no, there's a lot of screening tests that really aren't good for you.
Right, and that have been shown not to be useful. So it's not even about, it's not about the cost, although it is a huge waste of money that I think we always have to keep in our minds could be better used for other kinds of health care.
All right, before I open it up to you, in the news every week now,
yeah.
repeal and replace.
Here we go. Yeah.
So, first thing I want to get your take on, the Affordable Care Act.
Yeah.
Has it made things better than they were before? If you look
Yeah.
back before it was passed, what do you see as accomplishments? What do you see as issues?
Yeah, it did and it does, because it's still the law, some really important things. It gave people with pre-existing conditions the ability to have reasonably priced insurance. And again, because of gaming of the system, I started my New York Times series the year before the ACA took effect. I can't tell you how many patients I interviewed who couldn't buy insurance because they had asthma, or they'd once been on a pill for depression. You know, what constituted an exclusionary pre-existing condition had gone to like nobody, you know, really, if you were buying insurance outside of your company. I think it also changed the narrative somewhat in a really important way, that providing access to healthcare and good healthcare is part of a government's responsibility. It covered 20 million more people. Now, you look at that from outside the US and you'll say, well, 30 million people still don't have insurance. That's a problem. You know, you can look at that also from some areas where the premiums have gone up a lot. People tend to blame that on the ACA. I can tell you that those of us in the commercial sector have often faced similar rises in premiums that are quite high. Our employers often eat some of that. So when people say, well, why haven't I gotten a raise in the last 10 years? It's because a lot of that money is being funneled into those rising premiums, which maybe you don't see. So I think it did some really, really important things.
And what is it left undone? What are the problems?
The 30 million people are you know, and
What about issues of cost? People, I mean,
Yeah.
you hear stories of people who are paying more out of pocket.
yeah, and that's the thing, you know, both within the ACA, you know, people tended to blame everything they didn't like on the ACA and the health system. The ACA did not face these issues of price and cost head on, which every other country has had to do. President Obama's initial plan did, but those provisions were largely eliminated as he tried to get something passed. So I think until we face those issues of price and find a way to control price and cost, no plan, whether it's the ACA or whatever the American Health Care Act,
Right.
or Trump Care or Patriot Care or whatever it will be called in the future, will solve this problem of rising premiums, rising out-of-pocket costs. It is a huge problem, and you know, people experienced it and blamed it on the ACA, but it's really a system-wide problem.
All right, we've got about 10 minutes or so, 10 to 15 minutes for questions. I ask you to keep your questions short, and please have them be questions and not longer comments. And introduce yourself. And if it does go long, I may have to cut it a little shorter. So we'll start here and then work our way over. And we just say who you are. That'd be great.
Hi, my name is Ruth Rothbart-Mayer. Nice to see you. I ordered your book.
Thank you.
Medical schools give business courses now,
Yeah.
and is this conversation being incorporated of doctors being encouraged to have open conversations about pricing?
I don't think it is quite yet because I've given grand rounds at some medical schools, and one thing I hear over and over again from the residents is, we want to know about this. No one's telling us about this. You know, when we get these order sheets in the hospitals, we'd like to see a little price next to every box we check so we have a sense of what does it cost. And I feel like it gives me great hope, the people who are in medical school and residency now, because I hear from a lot of them and they're really upset. I had one radiology resident, and this was really brave of him to call me and say, I want my name in your book, because he was saying, look, I'm in a hospital where we're getting MRIs on every patient. And I know from my medical education that this is not right. He went to the hospital and said, I want to know how much you're charging. They wouldn't tell him. And so he wrote to me and, said, so I think there's incredible hunger. Whether the schools are doing a good job of that yet, I don't think so. And I think, I also see, which is somewhat disturbing to me, a lot of people offering MD, MBA programs. And it's not that I think people should be ignorant about business, but I don't think business should be the focus of healthcare. And I had one very disturbing conversation with a young man on the subway in New York, where you have a lot of conversations, who was a medical student doing research on Huntington's disease. And I said, oh, so you're going to be a neurologist? And he said, no, I want the patent. And I thought, wow, that's the wrong motivation for doing this. And at least for me, and I think.
Here in the front.
Hi, my name's Connie Roberts, and I just wanted to tell you another story about the cost of medicine and the ways they get around when it goes off patent. Mm-hmm. Well, what they do is, and I used to take Effexor, mm-hmm. and they now took the main ingredient and just changed it a little bit, and now it's Prestige, and
Right.
they charge more for that.
Right.
So it's another way, and there are several other pharmaceutical companies that do the same thing with a drug that is very popular, and they don't want to lose the patent, and they make it into something, like you said, with the melatonin.
Right.
You spend a lot of time talking about ways of getting
Yeah,
patent
I think
extension.
there are 9 different ways to keep your money flowing in from a patent and one of my favorite ones is one of the most popular birth control pills. They pulled it from the market and developed a chewable form and renamed it. Like lots of women are out there wanting to chew their oral contraceptives, but but I think this is something that has a policy solution that maybe Robert Wood Johnson would like to address. No, sorry, now I'm putting you on the spot. No, but I think, one thing we have to ask in terms of patent law is, should all pharmaceutical patents be the same? Shouldn't we have a different kind of patent for a truly revolutionary drug than for someone who's just reformulating an old drug? And right now, a patent is a patent is a patent, and I think that's something we can do something about.
Question there in the back. We'll come back to the front.
Hi, my name is Harold Simon, and I'm the publisher of Shelterforce magazine, and we just started a health and community desk, and Robert Wood Johnson's already funded us, so I won't hit you up on anything.
There you go.
This is a great session, and I just started reading your book, and it's awesome.
Oh, thank you.
Crisply written, blunt, and has so much face validity. So I wanted to ask you, something about the ACA, which you started talking about at the very end, and some of the positive things that it's done. And so from this little niche that we talk about, kind of the social determinants of health and moving upstream and looking at low-income communities, it seems more and more hospitals are collaborating to deal with this, both to lower their cost and managing to do that by, you know, what is it? Oh yeah, improving healthcare.
Yeah.
So, however, ACA is in danger, right? And so part of me is terrified that all of this will evaporate because I don't have to do it anymore. And other people have told me, well, you know, the hospitals that are doing this are actually kind of liking it because it is reducing their costs. They are seeing positive results, and then they're dealing with housing and food. So I'm both terrified and hopeful. So can you help me resolve this dilemma?
Well, I mean, the ACA, you know, I think we all have to remember, you know, the Republicans have been kind of dissing it for nearly a decade. It's a fairly new, huge, ambitious program, so it wasn't going to work well right from the start. You know, there were obviously going to be issues to deal with, especially since, you know, it created things like nonprofit insurers, the co-op insurers. Okay, then the Republicans didn't pass the necessary funding for that. So a lot of them have gone belly up. So it's had a very steep hill to climb. And if it's, you know, the Republicans don't have the votes to repeal it whole cloth despite what they're saying. But there are a lot of minor provisions that are really important for community health. One thing that's really I'm quite passionate about is the ACA for the first time required all the nonprofit hospitals to list what they do in the way of community benefit and charity care. Before that, they could just say, oh yeah, we're doing stuff. You know, these hospitals get huge tax breaks for serving the community, and some do a great job and some don't. And I think they need to be held much more accountable.
Do you see opportunities for common ground in terms of improving? You know, now that it's owned whole hog by the Republicans, you're Republican Congress, you're Republican in the White House. Do you think there's going to be improvements to the bill?
I don't know as a journalist if I can
Would you rather
predict.
not?
No, I think, you know, healthcare is a Rubik's Cube, and I think there are many people in DC who believe that whatever comes out at the other end will be essentially the ACA rebranded as Patriot Care, because there aren't too many ways you can make this work. And also, are you really going to take away health insurance from 20 million people, many of them in red states? And I think what we've seen now, and the reason they're having such a terrible time getting any bill passed, aside from the fact that they're, you know, created in 2 weeks and are not very airtight, is, you know, many of those people are in red states, and the governors and representatives from those states are like, you know, you see people at the town hall meetings getting up who are now realizing, and this was a major mission of mine, to connect the policy in Washington that sounds confusing and complicated with what's happening in your doctor's office and with your insurance. And I think a lot of people didn't do that during the election. You know, there was just this narrative, oh, we're going to repeal it, and they didn't realize that it was actually what covered their health care. And so now at these town hall meetings, you're seeing people getting up going, whoa, you know, don't take this away. So I think it's going to be really hard to...
I think we have time for one or two more questions here, and then come into the front after that.
Hi, my name is Juby George-Waze. I'm a nurse, 20 plus years in the industry, especially working in the managed care and the Blue Cross the last 10 years. But I left to start my own company focusing on the ACA to help chronic disease management. And thank you for mentioning about the orphan drugs and, you know, especially rare diseases, because my family is dealing with that, rare diseases, and Genzyme's $150,000 to $300,000 drug per year. It's horrible.
Yeah.
The question I have is because having looked at what is happening and helps run some of the programs that you see now, which is pay for performance, value-based bundles, what you're seeing is a lot of hospitals and organizations putting a lot of money and investing a great deal. For the next 3 to 5 years, you're getting a lot of money. But after that, they improve that quality, good patient. There's no more quality to improve on, and what's going to happen to that structure? Because nobody's going to keep reimbursing millions or thousands of dollars for whatever they're putting in place. Example is Dartmouth, who had to kind of close out their program. So I was just curious what you see, what is there to support this?
Well, I think, when you do value-based bundles, and just to give an example, one thing the ACA allowed CMS, the Medicare, to do was to create bundled payments for hip and knee replacements, which a lot of hospitals have been trying and have worked pretty well. And basically what that says is, okay, hospital doctors, everyone involved in this, we're going to pay you a set fee, say $35,000, and you guys figure out how you want to use it, because we know that with $35,000, you should be able to do a really good hip or knee replacement. In many places around here, you'll find that billed at over $100,000. And so what it requires is the hospitals to go and figure out which part of those procedures are really important and useful for patient care. And guess what? They discovered, the hospitals that have accepted this challenge, that the long rehab periods, inpatient, don't really add very much, that it's better, you can send people home with some instructions for exercise, which PS is what happens in Europe and happens at Kaiser Permanente for hip replacements. So what will happen? I mean, the problem is that hospitals have built for and staffed for a very inflated system with long-term rehab, right? And so what happens to those long-term rehab units? What happens to the cardiac rehab units when hospitals are paid a bundled price and it feels like, there's not a lot of value that we're getting there. I think downsizing the healthcare industry is going to be a big challenge. And since it upsized over 25 years, the big challenge is going to be, what does it mean for jobs and the economy? And I think that's...
So we'll take a last question down. Oh, there in the back?
Hi, my name is Melissa Grace Halleck. I used to be a Medicare and a Medicaid HMO salesperson. I used to enroll people in the health plans. And I've seen so many changes with healthcare and ACS, and I've experienced some of the things. And thank you for your book.
Oh,
I read it in 24 hours. It was just
Thank
delicious.
you.
And I've been buying it and giving it to the financial counselor at Mountainside and giving it to doctors, my pharmacist. I've literally done that.
This is great.
But aside from that, the minority community is my heart. And I see a lot of medical transactions that should not occur.
Yeah.
And I'm really interested as a community advocate for healthcare issues, because I've been in the corporate end and I'm at the street level where I'm talking to the Pookie and the Mookies and the Boo-Boo about healthcare with their kids and what they're doing and not doing. One of the things that I'd like to see from Robert Wood Johnson and from you as an author and a physician is how we can bridge the gap to educate and help the minority communities learn how to use healthcare.
Yeah.
And not use their card, which they see as a free go-ahead to the emergency room card, and not understand the actual components of it. And it's really something that I think if we don't educate and show this community how to utilize it properly, it's going to cost every single individual in here more in premiums.
Right.
And that's the population group, and that is the economic group that is fueling all these costs. So I'd like to hear a little bit more about what you think best practices could be for hospitals or community health centers or even organizations that are charitable that will help nonprofit organizations really help educate and teach this population group how to use healthcare as a tool, because it's costing us a lot of money. I'm seeing things that are not appropriate, like grandmothers who are becoming Dr. Moms in their houses and giving amoxicillin and penicillin and whatever medicine they get.
Okay, I think we're going to have to stop there.
It's serious.
No, and I think this is where when I say everyone should look at their local hospital's 990 tax form and read Schedule H, which is where a hospital has to say what it's doing for charity care and community benefit. There will be things in there that are like, that they consider community benefit, that are like, we held a farmer's market in the parking lot, and we sent our residents to to a retreat for a week. I would like to see that community benefit really be used for community benefit. And I think we should all ask more, or we should ask our hospitals to pay taxes, and we can use those taxes for that. One thing a nice example of this, and again, it's, at Hopkins, a good hospital, you look at the housing around Hopkins, the ambulance rides for asthma, they're sky high because we have a great system for kids for reimbursing visits to the ER for asthma, but we don't have a great system for helping families remove mold from their apartments, teach their kids how to use inhalers, make sure they have inhalers. And I think we really have to redirect those resources. And all of us, there was a judge in New Jersey who recently, a mayor sued and took away a hospital's nonprofit status. I think if hospitals aren't serving their communities, one person said to me, Apple gives away some computers each year, but that doesn't make it a charity. So I think we need to really ask more of these medical institutions to help the community around them.
Well, we just scratched the surface. The book is An American Sickness. Libby Rosenthal is going to be signing books. They're going to be for sale in the cafe. I want to thank you so much for.
I hope we talk lots more.
Thank you.
Thank you. That was fun.